recording. Okay. Bismillah ar-Rahman ar-Rahim. This lecture is being recorded. And we will continue with the anatomy and physiology of the gastrointestinal system. So if I recall back, last time we were just explaining about the functions of digestion and absorption in the small intestine. And we talked about the process of digestion of protein, lipid, and carbohydrates. Okay, and that was the last part we have described. Okay, so as you can see here in this figure here, so I just wanted to be familiar with the term barium meal. In general, barium study is a contrast study, which means sometimes we use some dye in order to visualize certain parts of the gastrointestinal system. It is, of course, with the help of X-ray. So what they do is that in the barium meal, from the name, it's a meal. So they give this liquid to the patient, and then the patient will drink it. And after drinking it, of course, according to the time, they will visualize certain part. For example, immediately after drinking it, they can visualize the esophagus. They give it some time, then the stomach, and accordingly later on, after a certain time, they can visualize the small intestine. So in the upper GI tract, if this visualization is done, it is called barium meal. Use of barium contrast study to visualize the upper gastrointestinal tract. We cannot use it to visualize the pancreas or the liver, only the hollow organ, because this dye will move with the food and it will attach with the walls, stain the walls. So while the X-ray is being taken, it's going to show these the outer part of the walls of the gastrointestinal system. It is important to diagnose conditions of obstruction or a tumor. It can show that there is some mass and the outline of the contrast is not clear, and there is something causing obstruction. And also sometimes the contrast is not moving to the next part. It is stopping in one level, which means there is an obstruction. So that's the help of this contrast study. Barium meal. There is another type of barium study which is used to study the lower GI tract. As we know, colon is one of the most frequent locations involved with cancer, colonic cancer. Now I think it's the second commonest type of cancer worldwide. So barium enema, which is the same material, but the study, it has a different name. It's called enema. I'm going to show you a slide later on. So that one is the same thing, but it is applied from the lower GI tract. From the anus, depending on the pressure, that will push that fluid from down up within the large intestine to stain the walls. And for the same purpose, it can help to visualize the lining of the walls of the large bowel and detect any case of obstruction. So just for that limit of that, what you need to know about barium study. So moving on into the accessory digestive organs. So as we mentioned before, the accessory digestive organs are these organs which are not within the lumen of the gastrointestinal system. And we started with the first one in the oral cavity. That one was the salivary gland, which secretes saliva and which starts the process of digestion. And then we have more of these accessory organs. Of course, as you can see in the figure, the liver in front of you, one of the most important and vital life-saving organs in our body, the liver. And you can see also the gallbladder, which is closely related to the function of the liver, and of course the pancreas. So these are very important accessory digestive organs that we hope to slightly touch on their gross anatomy. Of course, you remember from previous lecture the rules of the digestive elements released from pancreas. As we mentioned before, the protein, carbohydrate, and lipid digesting enzymes. and of course the role of bile, which is formed by the liver, stored and concentrated in the gallbladder, released by the gallbladder, especially when we are eating fatty meals. So this will help, especially in the digestion of fat. It helps in the emulsification and the absorption of fatty acids. So the liver, as you can see here in this figure, we remember from the gross anatomy of the abdomen, it occupies the upper right part of the abdomen known as the right hypochondrium. So as you can see here, it is below the diaphragm on the right side, and in doing abdominal examination, usually placing the hand and palpating the lower part of the chest on the right side usually will help to feel the margin of the liver. So the liver mainly is in the right hypochondrium and slightly to the epigastric region, and it is one of the largest glands in our body. And as you can see in the figure, it's on the right side, while you can see mainly the right lobe, which crosses the midline slightly, and then we have the left lobe, and then the stomach, which occupies part of the epigastrium and the left hypochondrium, of course. You can see also in the figure the transverse colon, which is running horizontally below the stomach, and then we can see the greater omentum attached to the transverse colon. As I mentioned, this is a part of the peritoneal double layer that stores a lot of fat. In addition, it has a lymphatic network that has also an immune function. But it doesn't play any direct role in the digestion or absorption. It is out of the lumen of the gastrointestinal system. So back to the liver, the largest gland in the body. As we mentioned, the location. Grossly, I'm sure you have studied in the laboratory about the different lobes. So in general, if you are looking from above, you can see only the right and left lobe, and we can see the falciform ligament, which attach the liver to the diaphragm above and anteriorly to the anterior chest wall. Okay. We can also, if you can see, I need to put the pointer better. Yeah. So you can see that the gallbladder is hanging from the lower surface of the liver, and this you can see. I hope you can see it now. I just used it right now. So you can see the gallbladder is hanging from the lower surface of the liver, and usually in physical examination it could also be felt, especially when it is inflamed in the right hypochondrial region. So the falciform ligament, as we mentioned, attached the liver to the anterior abdominal wall and to the diaphragm. And from the lower surface, we can see all the four lobes of the liver. These lobes are not equally divided in size. The largest, of course, as you can see, the right, left, and then the quadrate and the caudate lobes. So these are the four lobes of the liver. And you can see the gallbladder on the inferior surface, which of course plays a role in the storage of bile that is synthesized by the liver, and it will be stored in the gallbladder to be released when it is needed, especially with the fatty meals. So any meals with high fat content, immediately the gallbladder will contract, releasing the content of bile to enhance the digestion and absorption of fatty acids. So what are the functions of the liver? It is important to know these functions. So of course the liver is one of the most vital organs, like the kidney and the heart and the brain, that life couldn't last without it. So one of the functions is production of bile. So it is synthesized, it is made by the liver, and it is stored when it is released in the common hepatic duct. It is going to be stored in the gallbladder. So we don't have secretion of bile although the synthesis is continuously by the liver, but that secretion is going to be stored in the gallbladder and will be released upon the ingestion of fatty meals. So the storage will be in the gallbladder, which is in the inferior surface of the liver. What is the content? It contains the bilirubin, which is the end product of heme, catabolism, bile salts, okay, ions, water. So these are going to be released. Of course, there will be concentration, absorption in the gallbladder that will concentrate the bile more when it is inside there. Okay, so it helps to emulsify, facilitate the digestion and absorption of lipids or fat. That's one of the functions of the liver. Second important function is a storage site for glycogen. Now, glycogen and lipid. Glycogen is the storage form of carbohydrates. We all know that we depend on, our body utilizes the glucose, especially the brain and the red blood cells, as a source of energy. And therefore, we need to have a storage form of that glucose. And the storage is as glycogen. We have mainly two organs which are meant to store glycogen. The liver is one of them, and the second one is the skeletal muscles, which use the glycogen to produce glucose that will help to produce energy, fueling the muscle contraction. So in the liver, we have the glycogen that will help to release that glucose continuously into the circulation, especially when we are in starvation state. So usually during fasting month, especially in the beginning, we will be depending on the storage of glycogen to produce or release the glucose into the circulation, and that comes mainly from the liver. After, of course, it is depleted, no more glycogen is there, then the body will start to search for other sources of energy and other sources to produce glucose. So storage of glycogen and lipid is another function by the liver. It also one of the most important factories that aims to produce plasma proteins. So those patients with chronic liver diseases, they will have hypoproteinemia, low level of plasma proteins, because the factory is malfunctioning. These proteins such as albumin, which is a transporting protein, is there. In addition, many clotting factors are also synthesized by the liver. So one of the functions which is not mentioned here is that the clotting factors, which helps in the controlling bleeding, are also produced by the liver. So in addition, storage of fat-soluble vitamins. These are vitamin E, vitamin D, A, and vitamin K. These are the fat-soluble vitamins. They are stored in the liver. Of course, the liver most important function is to remove the metabolic wastes and toxins. There are a lot of toxins which are produced. Therefore, immediately after absorption from the gastrointestinal system, the blood will be moving through the portal circulation into the liver, whereby the toxic materials will be detoxified by the liver. So that's one of the most life-saving function, is the detoxification or removal of metabolic wastes and toxins from the circulation. Synthesis of plasma proteins, as I mentioned, detoxification, alcohols, drugs. A lot of drugs are actually metabolized by the liver in order to produce the active ingredients that is going to be treating the disease. In addition, sometimes certain drugs are going to be metabolized, producing some toxic products that will be also removed by the liver. Alcohol is also detoxified by the liver, and sometimes if the patient is alcoholic, this will overcome the dysfunction by the liver, and it might cause liver damage, as we all know, liver cirrhosis. It also, the liver is a part of the reticular endothelial system, which helps to remove the old red blood cells. As we remember, red blood cells have a lifespan of 120 days. Mainly, these cells, the old cells, are going to be removed by the spleen, but liver also play a role in this part to remove these old red blood cells. So very important to remember the detoxification and the synthesis of clotting factors and plasma proteins, in addition to the storage function and other things which are being described in this slide. While the gallbladder has simply one rule, which is storage and concentration of bile. And what is bile? We just mentioned that product consisting of bilirubin, bile salts, water, and it is important for the emulsification and absorption of how do we get gallstones? Well, sometimes there are some problems in the secretion in the gallbladder, and or sometimes there is problems in the flow of bile from the gallbladder that will lead to precipitation of the components within the bile. So they will similar to the mechanism of renal stones. So here renal stones, of course, from the glomerular filtration, the filtration will cause precipitation and making stones. Here also the bile disturbances in flow or in composition. If there is high composition of certain cholesterols, that might precipitate and lead to the formation of the gallstones that might obstruct the cystic duct or the neck of the gallbladder, causing problems in the release of bile into the small intestine, especially when there is ingestion of fatty meals. So that's why people with gallstones are advised to stay away from fatty meals, because their gallbladder storage and secretion capacity is very limited. So you can see here in the figure that in the liver there is a left and right hepatic duct that's joined together, making the common hepatic duct. And this common hepatic duct will release the bile that will be stored later on by the gallbladder. And then the gallbladder will absorb and concentrate the bile and release it through the cystic duct that will join the common bile duct, making the common hepatic duct joining the cystic duct that will make together the common bile duct. So common bile duct, there are also some variations whereby the common bile ducts will join the pancreatic duct in certain people before reaching into the small intestine. The end of this tract is going to release the secretions into the second part of the duodenum, if you still remember, through the ampulla of Vata, sphincter of Oddi, that will release the secretions from the pancreas. So here, this is the pancreatic duct, which is joining here the common bile duct, and these two ducts usually release their secretions together once the food particles reach into this region. So once the food is here, there will be a number of reflexes that will be activated, hormonal and neural reflexes that will inhibit the gastric motility, and at the same time they will stimulate the release of the digestive element to be released from the gall and from the pancreas. Okay, so you can see here those two elements. Important is to remember the names and locations of the bile ducts. These bile ducts, of course, could be blocked by a stone that is formed in the gallbladder, causing jaundice. We will talk about it later. Sometimes even the pancreas, you can see here, it's very close to the bile duct. So sometimes a pancreatic tumor will enlarge and block the bile duct, the common hepatic duct, causing backflow of bile to the liver. That will lead also to jaundice. That's why jaundice is very alarming if it is, especially when it is obstructive. So the bile, as we mentioned, secreted continuously by the hepatocytes, reaching the common hepatic duct, where it goes to be stored in the gallbladder, that will be released. So what is the element or the factor that will cause the release of bile from the gallbladder? That element or is a hormone. The name of the hormone, it is cholecystokinin. Um, there is another name or another part of this hormone is pancreozymin. So there is another term, cholecystokinin pancreozymin, which is mainly the hormone that will activate the release of the digestive secretion from the gallbladder and from the pancreas, especially when the food reaches to the small intestine containing the proteins, the carbohydrates, most importantly, the lipids and fatty acids. So these components will stimulate the release of the hormones. This hormone, one of them is the cholecystokinin pancreozymin. So cholecysto refers to the gallbladder. So if we want to say there is inflammation of the gallbladder, we will say cholecystitis. So cholecysto refers to the gallbladder. So this hormone will be released, and when it is released, it will stimulate the contraction of the gallbladder and the secretion of the bile to go through the cystic duct to the common hepatic duct, common bile duct, reaching into the ampulla of Vata to the second part of the duodenum to start the process of digestion. The pH levels, yes, it is very important to know that it is alkaline. You need to know the which part is alkaline and whether it is acidic. Okay? As we mentioned before, usually the food coming from the stomach is having an acidic pH due to the hydrochloric acid, so it will be immediately neutralized in the small intestine by the secretions which are released from the brush border of the duodenum and by the alkaline secretions from both the biliary tract and from the pancreatic duct. So these secretions will have an alkaline pH that will neutralize the acidity from the food coming from the stomach. So you don't need to remember exactly the components of the bile, but these are bile salts. Just say bile salts, they are enough. In addition to the bilirubin, cholesterol, water, that's it. So jaundice, I'm sure you are familiar with this term, jaundice, which refers to the yellow color of the skin and mucous membranes, usually seen on the sclera of the eyes, the whitish part of the eyes, especially when it is visualized under sunlight. And this yellowish coloration is usually due to high concentration of bilirubin. High concentration of bilirubin. Of course, there are many types because this bilirubin, for your information, is the end product of the heme, which is part of the hemoglobin of red blood cells. So if we have too many red blood cells dying due to some problem in the red blood cells, whatever it is hemolytic, and this will cause an increase in the production of bilirubin, and it will cause jaundice. That's why people with sickle cell anemia, thalassemia, they will have jaundice because their blood will hemolyze and increase the production of bilirubin. Another problem is that the factory that will conjugate bilirubin have a problem, like in liver cirrhosis, hepatitis, liver cancer, and that is called hepatocellular jaundice, where the problem is in the liver. That's another cause of jaundice. And if the production of bilirubin and the factory, which is the liver, are normal, sometime when there is obstruction in the bile duct, as we mentioned before, by a gallstone or by a pancreatic tumor or any mass that is blocking the bile duct, this will cause backflow of bile to the liver, and the bilirubin will be escaped to the circulation, causing jaundice also. So that one is called obstructive, when there is obstruction in the bile duct secretion. So all these three types are serious: the hepatic, the obstructive, and the hemolytic. Okay, so that's enough for jaundice. The pancreas, very simple information. It is retroperitoneal, which means it lies mostly into the in proximity to the posterior abdominal wall, and it is not covered completely by the visceral peritoneum. That's why it is known as a retroperitoneal organ. The pancreas, as we all know, has two main functions, an endocrine and exocrine. The endocrine part, which is not our topic today, you will mostly be familiarized with it in the endocrine system, which is the release of insulin and glucagon to control the blood sugar level. And the part which is related to the gastrointestinal system is the exocrine function of the pancreas that secretes the different enzymes that digest the protein, fat, and carbohydrates with the help of the duodenal secretions to digest the food in the small intestine. Again, the pancreatic duct will join the small intestine in the same ampulla of vata or the duodenal ampulla, which is reached by the common bile duct. Sometimes they join together before they make a one duct that will be open to the small intestine. And majority of people, it might open as two separate openings into the small intestine. So the large intestine, mainly the cecum, the first part, and the appendix, as you can see, section A. We can see the hostria, which is very characteristics to the gross anatomy. Why this difference occur between people? It's normal. It is like a normal variation between people. Large population, large percentage of people, they have either type, but in both conditions it is normal. Yes. So the cecum and the appendix, the beginning, and then as you can see the colon, we have first the ascending colon, transverse colon, descending colon, sigmoid colon, and then lastly the rectum, whereby it is guarded by the anal canal and anus, external anal sphincter, internal anal sphincter. Okay, so mainly the large bowel has little rules in digestion compared with the small intestine and stomach. Even in absorption, it has limited rule in absorption. Yes, it's going to be uploaded. Yes, the lecture will be uploaded. So the large bowel is important for the absorption of water and salts, and it has a very good absorptive capacity. In hospitals and in emergencies, they will depend they will depend a lot on the absorption in the large bowel, and a lot of medications, especially in children, are given into the large intestine instead of giving them orally or through intravenous or subcutaneous injections, because there is a very good absorptive capacity in the large intestine. So part of the water and electrolytes, but of course, if you've been asked in the exam, the main site of water absorption, the answer should be the small intestine. The small intestine is the main organ of absorption of all nutrients, including water and salts. Large bowel has no role in the absorption of fats or carbohydrates or amino acids, but it mainly concerned with the absorption of water and salts, sodium chloride, potassium, magnesium, okay, all trace elements. So, but of course, this rule is it is very minimal compared with the small intestine. In addition to the storage of feces, absorption of vitamin, like the formation of vitamin K, most importantly, by the presence of the bacteria within the large bowel, which is one of the fat-soluble vitamins. Okay. So, large intestine starts with the ileocecal valve, which is the valve that regulates the passage of chyme from the small intestine, the last part, which is the ileum, into the large intestine's first part, which is the cecum, and that's called the ileocecal valve. The name comes from both parts, and this valve will prevent the backflow of the chyme into the small intestine. So it will control the flow, and it will also regulate the flow between the small and large intestine. And as we mentioned before, the large intestine mostly is concerned with the reabsorption of water and salts or ions secreted earlier in the digestive system. And the bacteria also helps to produce and activate vitamin K, which is one of the fat-soluble vitamins, and it is very important, especially in the activation of clotting factors. Vitamin K deficiency can also be a cause of bleeding tendency. So the movements here, we have the haustral contractions that will help in the mechanical mixing and water absorption. In addition, there is a peristaltic movement that will help to propel the remaining of the chyme in the large bowel into the terminal parts of the large bowel, which are the sigmoid colon and the rectum. So once there will be accumulation and increased pressure in the rectum and in the sigmoid colon. This will create or start a defecation reflex, a spinal reflex, that will end up with the increased peristaltic movements of the sigmoid colon, and with the relaxation of the internal anal sphincter. And of course, the external anal sphincter is the one which is voluntaric, while the internal is involuntaric under parasympathetic. So when the defecation reflex starts, the internal sphincter will relax, and the only voluntary control will be external anal sphincter, which once relaxed, of course, will result in defecation, which is the process of passage of feces out of the gastrointestinal system. So with that, you understand now the different part of the gastrointestinal system and their functions. There is one regulatory part in the gastrointestinal system. We have already discussed part of it. If you still remember, we talked about the hormone cholecystokinin, pancreozymin, which is the hormone released in the gastrointestinal system. So these are endocrine, these are belonging to the endocrine function of the gastrointestinal system. However, their role is limited to the gastrointestinal system. So they are released in the gastrointestinal system, and their function is within the gastrointestinal system. But their release is into the blood, and that's why it is considered an endocrine function, not an exocrine. So they are released in response to the presence of food particles. One of these are the, if you still remember, the gastrin and the histamine, which are released by the G cells and enterochromaffin cells in the stomach. So once this hormone is released, it is important to remember that gastrin enhances gastric motility and enhances the gastric secretion. Okay, so these will enhance the hydrochloric acid, pepsinogen. Okay, so the secretion and the mobility and the motility in the stomach will increase in response to gastrin and histamine. Okay, most importantly, gastrin. This is important in multiple choice questions, because these hormones will be tricky, and you will need to know what is the right answer. So gastrin, from the name, it refers to the gastric. So it is stimulated by the food particles present in the stomach, and it will enhance the motility and the secretions from the stomach. Secretin, which is the another hormone released also in the gastrointestinal system. This one is inhibitory. So secretin, once it is released, it is inhibitory to the stomach and stimulatory to the small intestine and pancreas. So when the food reaches into the small intestine, secretin and cholecystokinin, both hormones will be released. And these two hormones will inhibit the stomach, inhibit the motility, and inhibit the secretion in the stomach. And at the same time, it will stimulate the secretions from the gallbladder and from the pancreas. So it will enhance the secretion of the alkaline products from the liver and pancreas to be released into the small intestine when the products are already there in the small intestine. So what will be released, so you can see secretin increases the pancreatic juice, increases the bile from the from the gallbladder, inhibits the stomach. Cholecystokinin also similar, increases the output of enzyme-rich pancreatic juice, stimulate the release of stored bile from the gallbladder, relaxes the sphincter of Oddi or the sphincter of the duodenal papilla, that will enhance the release of bile into the small intestine. So that means when the food is in the small intestine, these hormones will make secretions come into the small intestine and give some rest to the stomach to reduce motility and reduce secretions. So you can see here in the figure the demonstration of the functions of these hormones. You can see the gastrin released by the stomach, stimulating the stomach. You can see here secretin and cholecystokinin released by the small intestine, inhibiting the stomach, stimulating the gallbladder and liver. Okay, secretin also stimulates the, so you can see cholecystokinin mainly stimulates the bile part of the gastrointestinal system, while secretin mainly stimulates the pancreas. Okay, both of them, of course, at the end will enhance the secretions into the second part of the duodenum to enhance the digestion of lipid and protein and carbohydrates. So secretin and cholecystokinin are stimulatory to the pancreas and biliary system, and they are inhibitory to the stomach. Gastrin is stimulatory to the stomach. So somatostatin is another hormone. There are a number of other hormones which are less significant. Somatostatin, which is also known as the growth hormone inhibitory peptide, which similarly inhibits the gastric secretions, inhibiting the emptying also. Okay, so this is an inhibitory. It inhibits all secretions, all motility in the gastrointestinal system. We have gastric inhibitory peptide, which inhibits the stomach and enhances the release of insulin. So it is important to remember the function of each one of these GIT hormones. Okay, so just as we mentioned. So this is again the same process that I have just explained to you, whereby the food which is reaching into the small intestine from the stomach will enhance the release of the cholecystokinin and secretin, which will stimulate the secretion of bile and pancreatic juice to be released into the duodenum through the sphincter of the duodenal papillae. That will help in the digestion of lipid and proteins. They also stimulate the liver to secrete more bile that will help to further secretion of bile to digest lipids. So again, this is the same process of release of bile into the small intestine. This is the barium enema that I told you, which is similar to the barium meal, but the only difference, it is used to visualize the lower part of the gastrointestinal system. So this part here, it's about the lining of the peritoneal cavity. If you still remember, we talked about the presence of these covering the double layer and the fluid that is existing in the heart, the lungs, and in the peritoneum. Here, the lining is the peritoneum, the visceral layer. Okay, so as you can see here, as mentioned in embryonic development, most of these organs are going to be formed outside the abdominal cavity, and once they are pushed into the abdominal cavity, they will take a layer of the peritoneum with them. So when they are completely surrounded, there will be remaining a neck of double layer of peritoneum that will keep the attachment between the organ and the posterior abdominal wall. This attachment is going to be called mesentery. So the mesentery is the double layer of peritoneum that attach the organs to the posterior abdominal wall. Some of the organs are not. They will remain outside the abdominal cavity, and those will be referred to retroperitoneal. So retroperitoneal are going to be outside the peritoneum, such as the kidney, the rectum. Okay? So they will not have a mesentery, of course, because they are not pushed through the peritoneum into the abdominal cavity. Some of them, the organs will be intraperitoneal, and then they will become extraperitoneal. I will show you in the next slide. So here the retroperitoneal organs are incompletely surrounded by the peritoneum, such as the rectum. Intraperitoneal, they have the mesentery that attach them to the posterior abdominal wall, such as the jejunum. So here the figure shows you can see the attachments of these hollow organs of the gastrointestinal system to the posterior abdominal wall through this neck double layer of peritoneum, which are known as the mesentery. And the double layer of the peritoneum exists in the anterior abdominal wall, and that is called the omentum, which we have described, especially when we talked in the stomach. So we have the greater omentum and the lesser omentum, which are all peritoneal membranes, foldings within the abdominal cavity. So that's it. Here, this figure shows you, you can see here the different organs, whether they are intraperitoneal, retroperitoneal, or secondary retroperitoneal. Secondary is some organs, they are in the beginning intraperitoneal, but later on they become move slightly outside the peritoneal cavity. Examples of these secondary are the pancreas and the jejunum, in addition to the ascending and descending colons. So these are secondary. First, they are intraperitoneal, then they become retroperitoneal. While the retroperitoneal from the beginning, esophagus, rectum, as we mentioned, the kidneys, the ureters, okay? These are, the renal system is retroperitoneal. Intraperitoneal, we can see the stomach is intraperitoneal, the jejunum, the ileum, the transverse colon, sigmoid colon, okay? These are intraperitoneal organs. Last part, which is important for you to know, is the innervation of the gastrointestinal tract. So here, the innervation, we have intrinsic, which is inside, extrinsic, which is slightly to the outside. So extrinsic is the parasympathetic and sympathetic. If you still remember, parasympathetic enhances the function of the gastrointestinal system, while sympathetic system inhibits the gastrointestinal system. These are both belong to the autonomic nervous system. We have intrinsic innervation, which is a plexus of nerve fibers existing within the walls of the GI tract. So we are going very grossly describing these. So it is important for you to remember the enteric nervous system, which is within the walls of the layers in the gastrointestinal tract. One of them is known as the myenteric plexus. The myenteric plexus are the plexus that controls the peristalsis and the movement within the gastrointestinal system. And this plexus, or Erbach plexus, exists between the inner circular and outer longitudinal smooth muscle layers in the gastrointestinal tract. So it is between the muscle layers, and it controls the muscle action. It controls movement and peristalsis. My voice is not clear. Is it clear now? Is it clear now first? Okay, good. So I'm telling you that the enteric nervous system is important to remember. These two plexuses, one of them is submucosal, lying between the submucosa and the circular layer of smooth muscle. And the submucosal plexus is mainly concerned with secretions, secretory function, both endocrine and exocrine secretions with the gastrointestinal tract, while the myenteric plexus is the one which is between the two muscle layers, the inner circular and the outer longitudinal, and myenteric plexus is mainly concerned with the motility of the gastrointestinal system. Okay, so the location is important, the name is important, and the function is important. I'm going to show you a table that shows this. So we have the submucosal plexus, which is Meissner's plexus, and we have the myenteric plexus, which is the one controlling movement. So it is between the two layers of the smooth muscle, the inner circular and the outer longitudinal. And the function is motor. It controls peristalsis. It controls segmentation. The movements or the control of movements in the GI tract is mainly by the mentoric plexus, which is between the two muscle layer. While submucosal, between the submucosa and the circular smooth muscle layer, lies the submucosal plexus, which also has a name, Meissner's plexus. These plexus or nerve plexus controls the secretions, not the movement, the exocrine and endocrine secretions in the gastrointestinal tract. So it is important to know the names, the locations, and the functions of these two networks. In general, it is important to know that the sympathetic, as I just mentioned to you, the sympathetic and parasympathetic nervous system and their roles. Parasympathetic is stimulatory to the gastrointestinal system. It enhances the secretions, it enhances digestion, it enhances the absorption, it also enhances defecation, the sphincters will be dilated, while sympathetic, which is when we are in fight or flight, when we are in stressful event, then we are not going to neglect digestion. So everything in the gastrointestinal tract will be inhibited. Salivary secretion will be inhibited. The motility, the other types of secretions, all will be inhibited. The sphincters will be constricted. There will be no motility in the gastrointestinal tract, and the blood will be diverted to more important functions. Okay? So, yeah, that is important to know in relation to the gastrointestinal tract. We are not in the part describing the full function autonomic nervous system, only the part which is related to the gastrointestinal system. So parasympathetic is stimulatory, while the sympathetic is inhibitory. And when the sympathetic is inhibitory, it enhances the contraction of the sphincters. So this will stop movement of chyme between the parts of the gastrointestinal tract, while the parasympathetic will enhance everything, relax the sphincters to enhance the movement of chyme within the gastrointestinal tracts. So with that, I think we have finished the gastrointestinal system. One important acknowledgement, I have used the slides prepared by Dr. Sumaya, being taught to the same course of HSF 1 from College of Medicine. So thank you very much. If there is any question, I would... okay, I think the retroperitoneal and intraperitoneal, as I mentioned, the retroperitoneal are the organs which are outside the peritoneum. Mainly outside, they are posteriorly. So in the beginning, all of the organs are retroperitoneal in the development. Later on, within the development, these organs will be moving into the abdominal cavity. And once they move, you can imagine a plastic bag. And then what will happen, you are pushing something through that plastic bag. So eventually, when you push your hand, then you will find your hand coming out from the other side covered with the plastic bag. Okay? So the same thing happened in the abdomen. This is how the organs become intraperitoneum when they go into the abdominal cavity, and they will be surrounded by the visceral peritoneum, and there will be a neck of plastic bag which is still attached to the main layer of the abdominal wall posteriorly. That neck of double layer is known as the mesentery. So any organ which is surrounded completely by the visceral peritoneum and it has a mesentery attached to the posterior abdominal wall, it is going to be known as intraperitoneum. Those which are not having mesentery, they are not covered with the peritoneum and they are outside the abdominal cavity, are known as retroperitoneum, such as the rectum, such as the kidneys and the renal system. Some organs are first intraperitoneum and then they will be pushed posteriorly to be incompletely covered. Examples are the small intestine, the descending and ascending colon. Okay, so that's what is meant. It is important to remember the figure. There was one figure, I'd like you to remember it very well. Just let's go back into it. It shows different colors. Yeah, this one. So the figure here you can see. So what are the organs which are intraperitoneal, which means they have mesentery and they are enveloped by this visceral peritoneum, stomach. Okay. So esophagus is retroperitoneal. Duodenum is secondary retroperitoneal. The stomach is intraperitoneal. The pancreas is also secondary. Then after the duodenum comes the jejunum. So the jejunum is intraperitoneal. The ileum is intraperitoneal. The ileocecal valve and cecum are also intraperitoneal, while the ascending colon is secondary retroperitoneal. The transverse colon is intraperitoneal. The descending colon is secondary retroperitoneal. The sigmoid colon is intraperitoneal. The rectum is retroperitoneal. So the only two parts which are retroperitoneal from the GIT system are the esophagus and the rectum. Those are not covered by peritoneum. I hope it's clear. So I'm going to stop the recording of this lecture now. And I will try